Good morning, everyone. My name is John Spain, S-P-A-I-N. I'm the Executive Vice President for the Baton Rouge Area Foundation.
I'm Dr. Leo Swanee. I'm a pulmonary critical care physician and the Chief Academic Officer for Ochsner Health.
Dr. Robert Hart, Chief Medical Officer for Ochsner Health.
Hi, I'm Dr. Amy Feehan. I'm a research scientist with Ochsner Health and the principal investigator on this study.
It's John Spain again. I want to take just a moment to thank all of you for joining us today and for helping us to communicate the results of the Greater Baton Rouge Prevalence Study. The Baton Rouge Area Foundation is proud to have brought partners together from around our community to fund such a critical research project for the Greater Baton Rouge area. On behalf of the Baton Rouge Area Foundation, I'd like to thank our primary funders, the Louisiana COVID-19 Health Equity Task Force, the Humana Foundation, the Blue Cross and Blue Shield of Louisiana Foundation, Healthy Blue, the Pennington Family Foundation, the Wilson Foundation, and of course the Baton Rouge Area Foundation. This project truly represents a unique funding partnership of competing health insurance companies and their foundations working together for the betterment of our community. And at this time, I'd like to turn it over to Dr. Leo Swanee, the Chief Academic Officer for Ochsner Health.
Thank you, John. We can't thank you and the Baton Rouge Area Foundation enough for supporting this very important research. The more we can learn about this virus, the more that we will make informed decisions to keep our communities across Louisiana safe and healthy. As we planned for the study, an important part of the work was enrolling participants that truly represented all of the Greater Baton Rouge area. This includes by age, race, ethnicity, vocations, and geographically. I'm happy to say that we were successful in our efforts to represent the diverse community that is the Baton Rouge area. And the data that Dr. Feehan will share with you today was made possible by more than 2,100 community members volunteering to being part of this study. At this time, I'd like to turn it over to Dr. Amy Feehan as she will go through the results with you.
Thanks, Dr. Swanee. So after going through the data with our research teams, I'm excited to finally be able to share all of this information with you all. So first, just to get everyone on the same page, I wanted to cover the disease progression and why we use these two paired tests, which are the swab test or the PCR test to determine if you have an active infection, and the antibody test, which tells you if your body has generated antibodies to the virus. So if at time 0, you get infected with the virus, and where that blue line is shows kind of the progression of the disease. Some people go on to develop symptoms, others don't. And then eventually your body starts to generate antibodies to the virus, which is where you see the red line. So in that first group where people are testing positive for the swab test, but testing negative on the antibody test, those people are contagious at that point. So then they progress to producing antibody, and that's kind of the late stage of the infection when someone's recovering. And it's believed that these people are much less likely to be infectious. And then the last group are people who test PCR or swab negative, but antibody positive. So we know that they are recovered from the virus and have antibodies in their blood for some time afterward. So just to give you the raw data from our study, this is what the breakdown looked like. So in that first infectious group, there were 2.9% of people testing PCR positive, but did not have antibodies yet. So in our study, we just looked at people who were over the age of 18, which in Baton Rouge, that population is 551,185 people. So if you take 2.9% times that number, you get a projected number of infections, which is nearly 16,000 people who were infectious, but did not yet have antibodies. And interestingly, we found that actually 61% of those people were also asymptomatic, meaning they had no signs or symptoms of the disease at this point. If you look in that middle group where there was overlap with PCR positivity and antibody positivity, it was about 1% of the population. Again, 62% of those people reported no symptoms during this whole time. And then in the last group, 2.2% of people were over their infection and just tested antibody positive. And again, 54% of those people reported being completely asymptomatic. So here is a map of the 4 parishes that we tested in. The green dots represent our testing locations, and then the colors get darker as there's a greater concentration of active infections in this map. So those are the people testing PCR positive or swab positive, but not without antibodies at this point. So where there are zip codes that are grayed out with that kind of hatch mark, those had fewer than 10 participants. So I just didn't want them to misrepresent, you know, if 1 out of 2 people tested positive, it would look like there are 50% of infections there. So we just wanted to gray those out to create less confusion. So this is the map for active infections. You can see there are some hot spots, and that just generally speaking, infections are highly variable by zip code. And then I'm going to switch the map over to any positive test. So people who had an active infection or were in the late stage or past the infection. And this is what the breakdown looks like. So obviously it's a pretty big range, and again, just very variable by zip. So there's a lot of data on this slide, and I just want to orient everyone first. So this column represents the percentage of people who tested positive on any or both of the tests. So this represents any infection running down this way, and then it's the percentage by these the factors on the left. So in the second column where it says current infection, those are the people in that first group that were just testing PCR or swab positive, but didn't have any sign of antibodies yet. So those are the contagious people. And then in the past infection group, it's anybody who tested antibody positive, whether they were in the late stage of infection or completely past the infection. And then if you take that current infection percentage and multiply it by the number of people within Baton Rouge who fit the categories on the left, you get the number of infectious people that we're projecting were in the population by each category. So overall, we had a 6.6, and these are all census adjusted numbers. Overall, we had a 6.6% rate of infection, so had been infected at any time in Baton Rouge. 3% currently infectious people, and 3.6% of people had antibodies. And then you can kind of go down the columns and look at the different racial and ethnicity breakdowns and by parish. Here are some highlights to notice. So just like in New Orleans when we did this study, there were definitely racial disparities in the percent of people testing positive. Asian and white participants had a lower rate of positivity than Black or African American or Hispanic or Latino. And then if you looked at whether those were current or past infections, actually Black or African American were pretty similar to white in this case, but Hispanic or Latino had a very high rate of current infections. If you look at past infections, you can see that there's a really large disparity between Black and African American versus white or Hispanic or Asian. And then one other thing that really stood out is that there was a high rate of current infection positivity in Livingston and West Baton Rouge Parish, much more so than Ascension or East Baton Rouge. So now I'm going to present a bunch of different odds ratios, which just tell you how much more or less likely one group is to test positive versus another group. And so the group that we're testing is on the left, and what we're testing against is on the right. And then if these error bars that you see next to each dot cross the line at 1, that means they're not significant. So I've highlighted the ones that are significant in blue. So if you look at Black non-Hispanic individuals, they were 3.2 times more likely to test positive versus white non-Hispanic individuals. Hispanic of any race was 2.7 times more likely to test positive versus white. And then in the younger groups that we listed here, they were much more likely to test positive versus the 70+ group, which was pretty similar to anybody between the ages of 40 and 69. So if you look at the BMI categories that people fit into, BMI really doesn't have an impact on whether you catch the virus. So there were no real differences here depending on what your BMI looked like. So just to summarize some of our key findings, overall 6.6% of Baton Rouge area residents had been infected at the time of the study. And if you project that number onto the population numbers, that's over 36,000 people. Because we didn't allow people who had a prior positive test to participate in this study. The numbers that the state has collected at this point, which was about 17,000 positive tests, those are just in addition to the 36,000 that we found with our study. So we estimate that of these, more than 16,000 residents had a contagious infection at the time of testing, and nearly 10,000 of those showed no signs or symptoms. So the 60%, we found that 60% of infections were asymptomatic, and that prevalence was higher among minorities, particularly Black and Hispanic residents. Prevalence is also higher among younger people, like I just showed you. All right, so looking at some more odds ratios. For symptoms, which is the top panel, basically reporting any symptom gave you a higher odds of testing positive. But you can see that the symptom anosmia, which is the loss of smell and taste, really stands out. And that's likely because you can be tired or have a cough or runny nose for a lot of different reasons. There are a lot of illnesses that cause that. But anosmia is really unique to this virus. So you're actually 8.5 times more likely to test positive if you reported this loss of smell and taste. And then on the bottom panel, we're looking at comorbidities. And just like BMI, whether you had diabetes or high cholesterol or heart disease, that really didn't influence whether you caught the virus, but we know from a lot of really good research that if you do catch the virus and you have these things, comorbidities really influence what happens to you after you catch the virus or your outcomes. However, we did find that people who reported no comorbidities actually had a 1.5 times higher odds of testing positive. Okay, so in the top three here are looking at marital status. So single people were almost two times more likely to test positive versus married people. And divorced and widowed people were kind of in the same ballpark as married people. In the second grouping of three, we're looking at this group called 50-50, and those are people who are going into work part-time and working from home part-time. And that can include both people who are, on a weekly basis doing part-time at home, part-time going in, or people who worked from home in the beginning of the pandemic and are starting to go back to work now. So it includes all of those people. We're also looking at unemployed, laid off, and retired as one group, and then 100% going into work or 100% working from home. So out of these, the people who were 100% going into work were 2.3 times more likely versus that 50-50 group to test positive. And the other groups were similar to the 50-50 group. Next, we're going to look at a bunch of different job types. So we have like public-facing, childcare, healthcare. These are all compared to office workers, who actually have the lowest prevalence of any job type. So if you are working at a public-facing job like restaurant or retail or a police officer, you were 3.1 times more likely to test positive versus office workers. The delivery and door-to-door people were 6.3 times more likely to test positive, although in our sample, and I'll show you in the next slide, this was a very small number, so I wouldn't want to make any huge conclusions from this, but it did reach statistical significance. Healthcare, whether you worked in direct patient care or not, you were about 2.6 times more likely to test positive versus an office worker. And then this other group was 3.3 times more likely to test positive. So two more little risk factors at the end here. If you thought that you had COVID-19, you were actually 2 times more likely to test positive. And if you had a positive family member, you were 4.5 times more likely to test positive. All right, so here are the actual prevalence numbers. So you can see that if you had a public-facing job or you were in this other category, you were right around 9% testing positive. But if you were an office worker or you were working from home part-time and going into work part-time, you had a really low prevalence. And remember that our overall prevalence here is 6.6%. So this is well under the average. So just to summarize here, any reported symptoms were associated with higher odds of testing positive. Anosmia was really our standout symptom that could predict pretty well whether you were going to test positive. And then people without comorbidities were actually more likely to test positive. And office workers had the lowest prevalence of any work group we looked at. And finally, single people were more likely to test positive.
Dr.
So
Fian,
this-
may I break in for a second?
Yes,
I just want to clarify something. You said that you did not test people who had already tested positive, correct?
correct.
So that means if your study found 36,000 people were infected, it would be 36,000 plus 17,000 for the total number.
Correct,
at the
yes.
time.
Yes.
So what would the combined prevalence be with those two things together? Did you figure that
Oh,
out?
I should have had that number written down. I can do the math real quick and get back to you.
53,441.
For a population about 500,000, so about 10%.
Yeah, so about 10% altogether if you add those all up.
Try to break in. I just have an online thing here going on. I'll
Okay.
mute.
Okay. And actually, that is a good segue. I'm going to turn it over to our physician leaders at Ochsner Health, Dr. Swanee and Hart.
Thank you, Dr. Fian. That's a great job. I'd like to just talk a little bit about kind of the take-home messages for the public, and Dr. Hart and I will take questions afterwards. One, I think the fact that there's 10,000 infectious individuals running around the greater Baton Rouge area at the end of July that have no symptoms is very striking. And it speaks to how infectious this virus is and why it's been so difficult to control the spread of this infection. So in healthcare, we have a principle called universal precautions. And universal precautions means we have to treat every individual when we're dealing with an infectious disease crisis like this as if they were infected until proven otherwise. And I think for the public, one of the big take-home messages here is that we have to practice universal precaution in our everyday life and in the public. We need to wear our masks. When possible, we need to be able to do social distancing. And we need to have common sense. We cannot have large gatherings where we take our mask off and congregate in big group settings because we don't know who is infectious and who's not infectious when we're going about our daily lives. I think another important take-home message from the study, as we went over the prevalence about 10% in the greater Baton Rouge area, we're not near herd immunity. Even though we've had so many infections and it's been so catastrophic, we are not near herd immunity. We have many, many vulnerable members of our community still out there. And so it again emphasizes the point of universal precautions in wearing our mask. I think the other really important point about the study is that the disease doesn't spread through a community the same way, same rate, equally. It starts in certain areas and blossoms from those certain areas. So it helps our public health officials with the maps that you were seeing by Dr. Fian's research to know where should we put our resources. And we know who's at greater risk, and we know where the disease is spreading. And one example of that is the Hispanic community. We look at the data, we see most of the recent infections in the Hispanic community, and so that is an area that you would want to target as a public health official. So I think this data is very, very helpful that way. And then last, I want to emphasize the idea that we need to learn how to live with this virus. The genie is out of the bottle, and it's in our community, and and we cannot put the genie back in the bottle until we get a vaccine. And so I think it becomes all of us to work together as citizens of Louisiana to really help each other out and practice the things that we do know control this virus, which is wearing our mask, washing our hands, and practicing social distancing. I'll turn it over to Dr. Hart for some other comments.
Thank you. Thank you. This is Dr. Hart. Yeah, Dr. Swanee, that's a great point. This is going to be in our communities for at least 12 months, 18 months until we get a vaccine. I think your point that knowing what we know now, the idea of relying on herd immunity to be achieved in a natural environment is not something that we want to do. That's why vaccines are going to be important. That's why we're participating in some vaccine trials at Ochsner. I think the other thing that Dr. Swanee hit on is we know that these infections can occur out of clusters or small outbreaks. It's going to be very important in the future to be much more diligent about the testing and the contact tracing that comes out of that testing. So if you're at an event and people are positive, you may be contacted. You need to help participate in that so that all the people that are there that may have been infected can be contacted and take the appropriate measures, the self-quarantine, to avoid spreading this. Because it really gets back to what a lot of this information shows. There are a large number of people that are asymptomatic that can be spreading this disease. An individual cannot rely on feeling bad, feeling symptomatic, and letting that be the indicator of when or when not to wear a mask. We have to get used to wearing our masks all the time. So knowing this is going to be in our environment, what do? Dr. Swanee said, we wear our masks, we socially distance. But this doesn't mean, because of this asymptomatic state, this doesn't mean that we just go in our homes and do nothing. We should be getting out. We should be, we've shown here, we can go back to work safely. We can go back to school safely. We can do things out and about safely. I think early on, there was a sense that we had to choose either health or choose, say, opening up the economy. I think what we're seeing is if we do the right things with what we're learning with the masks and the social distancing, we as individuals will be able to do more, will be able to become more active, will be able to do more to advance the economy if we will continue to practice these things. On an individual basis, though, every individual needs to assess their own individual health risks. What may make sense for an 18-year-old will not make sense for a 70-year-old with diabetes and heart failure who might be overweight. So every individual needs to assess those risks. So just want to be clear, this does allow us, this information does allow us, knowing what we know about the asymptomatic spreaders, that if we wear our mask, we know it's effective. We have seen it work in our state. We've seen the numbers come down when we started wearing the mask more. We need to continue doing that. We need to be diligent about that and the social distancing.